Hi all, it's Jess, and I'm continuing my series on endocrine problems. So for the next few minutes, I'm going to be talking about hypothyroidism, that slowing down of the metabolism. So let me share my screen and we'll get started. So there we go. Hypothyroid is, again, on this continuum of thyroid dysfunction. So another couple of YouTubes talks about hyperthyroidism, where you have this like hypermetabolism. So thyroid hormone is all about metabolism. You can have a neutral thyroid, which is the zero thyroid condition. But when you're working with somebody who has hypothyroidism, be aware that they can actually move from hypothyroidism into a coma just because of metabolism reasons. So hypothyroidism is basically there's not enough thyroid hormone. And so that causes a general slowing of the metabolic rate. So any of you who have seen Zootopia have seen the sloth at the DMV, right? Dude has hypothyroidism if he were human. So subclinical hypothyroidism is classified as a TSH greater than 4.5 milliliters per unit of, anyway, that. So, sorry, coffee. Remember, TSH is sent out by the pituitary gland, and TSH is designed to be a messenger to thyroid hormone, or to the thyroid to release thyroid hormone. So if you have a lot of TSH, the pituitary gland is aware that there is a problem, and the thyroid gland just can't keep up. So the T4 levels will be normal. There is a about 10% of women over 60 have problems with hypothyroidism. There is also a non-thyroidal illness syndrome. This creates critically ill patients because they have low T3, low T4, and low TSH. And that means that they have a more global endocrine problem. This is more common in women and in men than in men. And just in general, hypothyroidism is more common in women than it is in men. Manifestations include slowing of body processes. It's a very slow onset. This doesn't happen. It's not like a light switch where you have like enough thyroid hormone and then you don't. What will happen is people will get really tired. They'll get lethargic. They'll have an impaired memory. Their get up and go has got up and went. Low initiative, people will gain weight. The other thing is they will have some decreased muscle contractility. So they have weakness in their skeletal muscle and in their cardiac muscle. And that lowering of the cardiac output, meaning their squeeze isn't very good in the heart. So if they don't have good squeeze in the heart, then they're not delivering oxygen. So then that makes even more fatigue and weight gain and lethargy and impaired memory. So we have this whole like cyclical thing where it's like, I don't have enough metabolism, or I don't have enough thyroid hormone. I have a slow metabolism. I have all of this stuff, and then it just keeps feeding itself. I can't think. I can't keep my memory straight. I have weight gain. I'm getting weaker. I don't want to work out, and it just kind of keeps going and going and going and going. Neurologic system, like I said, fatigue and lethargy, personality and mood changes. These people can be a little bit short, and they can be a little bit easily cranky. They will have impaired memory, slowed speech, decreased initiative, and somnolence. The GI system, they will have a decreased appetite. They just won't be hungry. Nausea, vomiting, perhaps. weight gain, constipation, and the nausea, vomiting, weight gain, constipation all go together. It decreased appetite. I mean, it's all GI systems, don't get me wrong. But like, if you're not exiting your byproducts of eating, you're not going to want to eat. So that lack of exiting, just like when you have bowel obstruction, causes nausea, vomiting. If you don't have any GI motility through your colon and through your intestines, you're going to have nausea and vomiting just because you're not pooping. A distended abdomen is common, an enlarged scaly tongue, and celiac disease, where they have that that hyperreaction to gluten, and a gluten, more than a gluten intolerance. A myxedema coma, what happens slowly and slowly and slowly, if we don't get on top of it, the body will just shut down. Usually what happens with a myxedema coma is there's some sort of infection, not like a head cold, like they live in Minnesota cold, they live in Alaska cold, they live in the Northwest Territory of Canada cold. Trauma can trigger this as well, and some medications. So there's impaired consciousness. There is subnormal temperature, so their body temp will just be low. Instead of a 36.8, they may be running a 35. Hypotension, hypoventilation, so their blood pressure will be low, their mean arterial pressure will be low, and their blood pressure over, or their ventilatory, they'll be like breathing at like 6, 8. And this creates a cardiovascular collapse. How we reverse that is we give them some IV thyroid hormone. So here are some different features of that myxedema. This is before coma, clearly, but she's got dull, puffy skin, sparse hair, periorbital edema, like that's around the eyes. Here, grab out my laser pen again, right there, periorbital edema, and a prominent tongue. So this is kind of how a person, over time, their physical appearance manifests with hypothyroidism and myxedema. If this person doesn't get treatment, she'll go into coma. So diagnostic studies will be testing their TSH. Again, that's that thyroid stimulating hormone coming out of the pituitary gland. We'll also be checking their free T4. So just to let you know, TSH increases with primary hypothyroidism. So if you have a primary hypothyroidism where your thyroid gland just needs a kick in the pants, you will have a lot of TSH because the pituitary gland is trying to kick the pants of the thyroid hormone, or of the thyroid. If you have TSH the TSH will decrease with secondary hypothyroidism. So if the pituitary gland is the problem, because it's a two-step process with thyroid hormone. So if there's not enough TSH, then the thyroid hormone isn't going to put out anything. So for whatever reason, you have a pituitary problem. Perhaps you have a tumor, perhaps you have a head trauma, perhaps there's swelling. But again, this is like a long time over time situation. Thyroid antibodies can be tested to see if the thyroid isn't being attacked from within, as well as we're going to take a look at cholesterol, triglycerides, creatine kinase, and RBCs. So the interprofessional team's goal is to get to that neutral thyroid state as safely and as rapidly as possible. We'll be implementing or having them implement a low-calorie diet, and we'll be having them do hormone therapy. So levothyroxine, otherwise known as Synthroid, people start with a low dose because this is basically metabolism increasing medication. So we'll be monitoring these clients for chest pain, for weight loss, for nervousness, for tremors, for insomnia. Basically, levothyroxine in a person that has low thyroid hormone is in some ways, you could think of it as kind of like prescription speed. Or if we were to take it as healthy people, it would act a lot like caffeine. It's a stimulant, caffeine, or sometimes people take somebody else's Adderall and they're not supposed to, or something like that. We will increase the dose in 4 to 6 intervals based on the TSH levels. So a person will start out with a tiny dose, usually 37.5 micrograms of Synthroid, and then a month later, 6 weeks later, we'll check their thyroid TSH levels, and then we'll keep increasing it until we can get to those TSH levels less than 4.5. This is a lifelong thing. This is not an antibiotic. This is not a 2-week deal. This is not a 3-week deal, and then all of a sudden it's done. This is now a chronic condition that the person's going to have to manage, and they should be educated about the clinical manifestations so that way they know if they've got enough thyroid hormone coming in through their Synthroid. So I'm going to stop sharing, and I'm going to continue on with nursing management of hypothyroidism in another YouTube.